Yes. Give me a second. Can you guys see me? Can you guys hear me? Hi, hello, and how are you? Hello. I hope I'm audible and visible. Good evening, everyone. So today we are going to start with Good Evening Land. We're going to start with a new chapter of neoplasia. Okay. I hope I'm audible and visible. There are two things that are very close to my heart. One is genetics, and the other one is neoplasia. Because I do report only these two in real life. I do report few of give second opinions for cancer slides, and also I look at the cancer slides and help in the diagnosis. That's the molecular pathogens and diagnosis of the patient. So that helps in the treatment management at the end of the day. Fine. Good evening, Swati, and good evening, Line. So I want to cover neoplasia, almost everything, whatever is there in Robbins. Let's take it slow. It doesn't matter. If you're an essential batch student, we'll go in a different pace there, and I'm going to go in a very different pace here, right? At some point of time, this will overlap, and the essential batch will be covering a little bit faster than this. Here, I'll go step by step, which I want you to have a very strong base, so that when you go to your third year, when you go to your final year, and as a doctor, you'll have much more strong understanding of what cancer it is, because that's very important for me rather than just learning for an MCQ purpose, right? Good evening, Pratna. Good evening, Vishnu. Okay. So today's class on neoplasia, as you can see, is going to be primarily on the basic terminologies of cancer. So whatever we are going to name in cancer, that's very important. If you're with me from the start, you must know that everything in pathology is based on terminologies only. Fine. Amazing, Salman. Hope it is good. Okay. So what we're going to learn is today we're going to learn why I'm going to name a cancer this, and if I have any cancer in down the road in my future, I can easily name that cancer even if I don't know anything about it. Right? That's a basic terminology. That's what we're going to learn today. Right? Now I'm going to write a few names. I want you to guys to comment on what is your idea. It's not about being right or wrong. Just tell me what you think about them. That's all right. Good evening, Nayak. A term tumor. Okay. A term neoplasia. What do you understand by these two terms? Tumor and neoplasia. What is your understanding? Can be anything under the sky, but just do comment like what do you think of something is named as a tumor, something is named as a neoplasia. What do you think about them? A tumor and a neoplasia. Tumor is a swelling. Fine. I just want answers like this. That's more than enough, right? Perfect. Tumor is swelling. What you read from your second chapter, right? Ruber, tumor, to dollar, and everything, right? Abnormal growth of tissue is a tumor. Abnormal cell growth is tumor. Whatever you're saying is right. Maybe benign, maybe malignant. Absolutely right. Tumor is swelling. Absolutely right, right? So tumor means a swelling. That's all. Neoplasia means a new growth. That's all right. So the literal translation of a tumor is swelling and a new growth. Those are the literal translations. But for me, for application purpose, because understanding is one, application second one, right? So these two terms you'll be using throughout your medical career for any lesion which is having an abnormal growth or an abnormal growth, like someone of you said, it's just an abnormal growth. That's all, which can be benign or malignant. It's not restricted to benign lesions. It's not restricted to malignant. It can be either benign or malignant. Both of them, I'm going to use the term tumor. Right? That's what for me tumor means. Tumor means it's anything benign or malignant. It's a swelling. It's an abnormal growth. That's all, right? It's not only for benign. It's not only for malignant. Can be benign. Can be malignant. That's the first term, right? Next for me, if you take in general the origins of tumors, can anyone tell me any tumor you know? Whatever tumor or cancer, whatever comes to mind. Just one example. There are many of you guys here. You can get lots of examples if all of you start commenting, right? A smooth muscle tumor or a squamous cell carcinoma or an adenocarcinoma, sarcomas, many things, right? So whenever I have any tumor, I'm going to have two different things. That's my origin. So for origin, I broadly divide them as, okay, I have leukemia, I have brain tumor, lots of them, right? Origin, I broadly divide them as epithelial origin, that's one. The other one for me is an mesenchymal origin. Okay? Broadly divide them based on origin of the lesion, right? So for anything which is an epithelial origin, the base for naming, see, I'm not going to the suffix, I'm just coming to the base, that's all, right? Okay, just the base. The base for terminology or naming for an epithelial tumor is microscopic appearance. I name them based on how they look in microscopy, that's all. For any epithelial tumor, be it benign or be it malignant, if it's from an epithelial origin, I name it based on the appearance. Every mesenchymal tumor, I always name it based on the origin. Naming is always based on the origin of the tumor in mesenchymal, and for epithelial, name is always based on the microscopic appearance. I'll give you an example. What do I mean by this, right? Let's assume you must have definitely learned about a tumor, what you must have read in Samoma bodies. Can I say a thyroid tumor? What comes to mind when I say Samoma body? Papillary carcinoma thyroid, right? So it's an epithelial tumor, right? It's definitely an epithelial tumor. Anything which is epithelial, if in microscopy, I'm going to see structures like this, I'm going to name it a papillae. That's all. A papillary carcinoma of thyroid or a papilloma, squamous cell papilloma, right? That's what I'm going to name. If in microscopy, I'm going to see structures like this, I'll call them, this looks like a gland, I'll call them adenocarcinoma or an adenoma. If it's benign adenoma, if it's malignant adenocarcinoma. I always name on how it looks in microscopy. A papilloma could have come from squamous epithelium or a columnar epithelium, doesn't matter for me. If it's papillary in appearance, I call it papillary carcinoma, that's all. It doesn't matter where it's coming from, squamous or your columnar. But here, mesenchymal is always based on origin. Let's say it's arising from blood. I call it leukemia. Leuke is for the blood, right? White blood, leukemia. If it arising from your lymph nodes or lymphatic tissue, I call it a lymphoma. It's always based on origin. Obviously, the blood tumors are mesenchymal tissue, right? Let's say I'm having a tumor arising from fibroblast. I call it a fibroma or a fibrosarcoma. It's always based on the origin. If it's a mesenchymal malignancy, I can call it a fibroma. If it's a benign or if it's a malignant, I can call it fibrosarcoma, right? So if you know the origin and if you know how it looks, you can name an epithelial tumor. If you know the origin and if it's a mesenchymal tumor, you can already name it. You just add the suffix of OMA. Anything which is suffix of OMA is equivalent to a tumor. That's what tumor means. I'm just going to add it. Lymphomas, yeah, or a fibromas, or your neurofibromas. Someone said it's coming from neural tissue, right? That's all. That's the origin here for me, right? So this is the basic difference between naming of an epithelial tumor and naming of a mesenchymal tumor, right? And then there are malignant tumors. Malignancy again is important for me. If I'm having a malignant tumor, again I have two origins, epithelial and mesenchymal. If it's an epithelial malignancy, what is the suffix we add? What's the suffix for every epithelial malignancy? Squamous cell or an adeno or a transitional cell, we call it carcinoma, right? Perfect. We call it carcinoma. So it's based on the suffix. The suffix is carcinoma. Anything. I can add carcinoma to everything there, right? What do you think will be the suffix of a mesenchymal tumor? Leave the hematolymphoid. Rest of the mesenchymal tumor, what will be the suffix? Fibro or a leiomyo or a rhabdo, we call it sarcomas, osteo, chondro, right? All of them we call them sarcomas. Okay. So this is a basic definition of why I call it a malignant, fine? Okay. I'm going to give an exercise to you. I want you to try and answer the tumor. This tumor might have been very, very new to you. You must have not heard about this tumor, but still there is a possibility you can name it based on whatever basic understanding we got, right? Let's assume a tumor in microscopy looks like this. Okay. A tumor in microscopy looks like this. I have multiple structures like this, fine. Can I call it gland? Kind of looks like a gland. Yes. Okay. But unfortunately, it's not just the gland. There are multiple tiny areas with lots of tumor cells here. Can I call these tiny areas cyst? Can I call them? Yes. So having a gland like structure, because it's not exactly a gland, because glands won't have tiny cysts, right? And here in the microscopy, I'm having tiny cystic architecture. Can anyone name this tumor? And this tumor is coming from epithelial origin. It's coming from epithelial origin. Can anyone name the tumor? It's an epithelial origin, have a gland-like structure with tiny cystic space. What does oid stand? Like means oid, right? Gland means adeno. Swati is partly correct. Cystic carcinoma is fine, but the first half, the microscopic appearance is very important for me. I name this an adeno-like, so adenoid cystic carcinoma. So I can name the tumor if I can have a clarity on what I'm going to look for. That's all. Right? I won't call it exactly adenocarcinoma aria for the only reason adeno means a perfect gland. Here I'm having adeno plus a cyst-like lesion. So it's an adenoid cystic carcinoma. That's how I name a tumor of epithelial origin, right? The same rule can be applied for any tumor of any epithelial origin. This is a microscopic appearance. Mesenchymal always based on that cell of origin only. Fine. Okay. So this is your basic naming here. Now let's have a quick look about few new namings. See, I have a tumor which is coming from epithelial origin. I can name it. I have a tumor which is coming from mesenchymal origin. I can name it. If you have a tumor coming from a very primitive stem cell, what do I do? Like let's say a yolk sac. Yolk sac can go in any different direction, right? Or a very like a blastocyst, it can go in any different direction, right? If the tumor has more than one germ layer, so what do I do? Okay. I have more than one germ layer, so what do I name? There are two tumors with more than one germ layer. One with a microscopic appearance of more than one germ layer. Second, I have a tumor per se where the origin is more than one germ layer, right? So if I have a tumor which is going to arise from very, very, very immature cells, right? You're right, teratoma, right? If the origin is again from a very immature, or we call it an totipotent stem cell. Totipotent stem cell is a cell which can give rise to anything, right? It can give rise to your RBC, WBC, platelets, epidermis, mesodermis, everything here, right? Hello, heat. Okay, so that we're going to name it as an teratoma. Okay? We're going to call it a teratoma. If the origin is very, very, very early, totipotent germ cell, I use term teratoma. This doesn't mean that it comes only in testis and ovary. I can have totipotent germ cell in many parts of the body, so teratoma can happen in many parts of the body. Fine, that's one. Second, my origin is not from my totipotent germ cell. The origin, let's assume, origin is from epithelium only. Okay? For me, origin is from epithelium. But what I see is, in microscopy, I am seeing something different. It's not having only epithelium in microscopy. In microscopy, I have both epithelium and I have mesenchymal tissue. Okay? I have both epithelium as well as mesenchymal tissue in microscopy, and in your origin, it's coming only from an epithelial origin, right? So this epithelial in microscopy shows glands. I'm just making the base for us to name it, that's all. So if it's microscopic glands, what will be the term which you're going to use? I want everyone here to come on. It's fine if you're wrong, it's completely fine. The microscopy as glands, I use the term adeno, right? Perfect. I can call it adeno. But unfortunately, I'm not just seeing epithelium, I'm seeing mesenchymal tissue also. I'm seeing more than one. Do you know any term for more than one or multiple? Do you know any term for it? I'm having multiple morphology here. Do you know any term for that? Not only one morphology, multiple morphology. I'm having epithelium, I'm having mesenchyme, but it's coming from epithelial originally. Can I use the term pleo? Pleo means multiple, right? So I'm going to name this exactly what I'm going to see in microscopy. The pleomorphic for morphology and adenoma. Okay? It's a pleomorphic adenoma, that's it, right? Pluri is one, pleo is another one, that's all. It's multiple, that's all, right? So I call it a pleomorphic adenoma. Perfect, right? That's how we're going to name it. So this tumor has one more name. We call it a mixed tumor of salivary gland. It's called as mixed tumor. Pleomorphic adenoma happens most commonly in salivary glands. That's a tumor. That's the most common origin here. Fine. Salivary glands, right? So these are more than one germ layers. If it's only one germ layer, it's very simple for me. If it's epithelium, I look at the microscopy, I name it. If it's a mesenchyme, I look at the origin and I name it. If it's a benign, you just add OMA If it's malignant epithelium, you had carcinoma. If it's a malignant mesenchyme, you have sarcoma. As simple as that, right? It's very, very simple. There are few places where I can have more than one germ layer, like this. If the origin is more than one germ layer, like from totipotent germ cell, I call it teratomas. If the origin is only from one epithelium, but in microscopy I'm having more than one cells, a pleomorphic adenoma. I call it a pleomorphic adenoma because I'm having in microscopy more than one thing, right? So these are few basic terminologies required for me, right? Next, again, a very few basic characters of a cancer. Okay. One, every cancer, what you're going to see from today on, or every tumor. Tumor means it includes both benign and malignant, right? For every tumor, this is true. Every tumor will be monoclonal. I never want you to miss this. Every tumor in my body will be monoclonal. Monoclonal means mono is single, clone is clone. That's all, right? Monoclonal means all cells in a tumor is originating from has the same origin. That's what I mean by the term monoclonal, right? Let's learn why this is important for me. Fine. Okay. Just give me a second. Okay. So it's about monoclonality, right? Every tumor, whatever we see in your life, is monoclonal. The reason why I have to understand this is, let's say, do you remember what's the other name for PCAM? What we read in inflammation chapter, PECAM1. Any other name for PECAM1? Have you heard about that? We read about PCAM1. You also said that's a CD marker, CD31. Perfect. So CD31, can I say CD31 is present in endothelium? Yes, is that statement right? It has to be present in endothelium, right? Okay. So tumor coming from endothelium, will it have CD31? They will. That's my tumor marker. So I'm going to use marker profile, that's all. Monoclonality is going to help me to identify the markers, that's all, right? So tumor coming from this, or tumor of endothelium, will be CD31 positive. So that's how I'm going to use. So if I know normal, knowing abnormality is not difficult at all, right? Just one more example. Have you heard about a cell called as a parafollicular C cells in thyroid? You must have, right? You must have definitely read. So what do you think is a function of parafollicular C cells of thyroid? What do they secrete? You must be experts in physiology. What do they secrete? They secrete acetone. Perfect. So I have a tumor, okay? I have a tumor coming from parafollicular C cells called as medullary carcinoma of thyroid. So medullary carcinoma thyroid's marker is calcitonin. That's how it is. So in other words, if I know normal of any organ, if I have a tumor from that, I can use them as a marker to diagnose. It's very, very simple. And for an undergraduate, it will always be well differentiated tumor will be given for you. Don't worry about the outliers. Outliers is not my concern at all. So every tumor, whatever you read from now will be monoclonal. It's not just for benign or malignant. It's for both benign and malignant. They will be and must be monoclonal only. That's one term which I want you to remember for sure. Fine. Second thing for me here is this can be applied only for cancers. Most of the cancers, if not all the cancers. Cancers will always be hard on palpation. Will always be hard on palpation. Whenever you go to a surgery posting, you see a breast mass which is going to be hard on palpation, you call it a breast cancer, or at least you suspect it's a breast cancer. This is true for any cancer in the body with a very few exceptions. The reason and for this we'll see, and also there's a name for it that also I want you to know. That's a basic terminology given, that's all, right? So first question, why is the cancer hard on palpation? That's my first question, obviously, right? Let's take an example. Let's assume I'm having a epithelium or skin. Okay, let's assume there's skin here, and I'm having here dermis. Just an example. I'm having a epithelial cancer, that is squamous cell carcinoma. A cancer coming from the epidermis, I'm going to call it a squamous cell carcinoma. So you know for a fact, I can call it as a cancer in microscopy only when it crosses basement membrane. So this tumor, let's assume this is my basement membrane, right? crosses this basement membrane, goes into my dermis. Okay? When it is going to damage or destroys basement membrane, and it invades into dermis. Invasion is a classical finding for malignancy, right? Okay, it damages basement membrane, okay, and is going to invade into dermis. So I'm going to call it a cancer. Only then I can call it a cancer, otherwise I cannot call it a cancer, fine? Okay, ignore it, it's getting separated far away. So now you tell me, if I'm going to call a cancer only when it invades, can I say if a tumor crosses basement membrane and it goes to dermis, is it causing damage to the dermis? Yes or no? A cancer is damaging dermis, yes or no? Absolutely yes. It is definitely damaging dermis, right? Perfect. So if it damages dermis as a response to tissue injury or wound healing, will there be a scar tissue? Will it have a scar tissue? 100% will have a scar tissue, right? Perfect. Now here, so this damage to the dermis will definitely have a wound healing. It has caused a wound and the wound will definitely heal. Healing is always by scar, and scar is nothing but fibrosis. That's all, right? A fibrous tissue, will it be soft or hard? It has to be hard. So every cancer will invade, should invade. If it is not invading, it's not a cancer. If it invades, it will cause a wound, skin or GIT or lung. It will invade for sure. And healing is always by scar tissue, and that's the reason it's hard on palpation. So every cancer will be a hard mass, and I'm going to give a name to it. Hard fibrous. The reason for hardness is here fibrous tissue, right? So I call them as desmo for fibers and plasia. So plasia is for your mass tissue for sure, right? It's desmoplasia. This means they are nothing but fibrous growth. Okay, that's true for every cancer, whatever you're going to see in life. It will be hard on palpation. You know for a fact, desmo means fibers. In your first year in anatomy, have you heard something called as syndesmotic joints? Your pubic symphysis, that's a syndesmotic joints. Syndesmo, it's union, right? By fibrous tissue. So desmo means fibers. So they call them desmoplastic growth, right? So whenever you read desmoplastic growth or a hard tissue or an induration clinically, think of a cancer. Because a benign tissue will very hardly be fibrous. It will not be generally hard on palpation. If it's hard on palpation, one of the thing for me is cancer for sure, right? So these are few terms I wanted to understand. Just quickly go through it. Tumor, oma, and neoplasia. All of them means they are tumors. They are benign or malignant. It's an abnormal growth. That's all. I have two big origin: epithelial and mesenchymal. If something is coming from epithelium, I name it based on the microscopic appearance. If something is coming from mesenchyme, I always name it based on the origin of the tumor. Example: papillae, papillary carcinoma; glands, adenocarcinoma. Your anything in mesenchyme: fibrosarcomas or fibroma; smooth muscle, leiomyosarcoma; rhabdo is for skeletal muscle, skeletal muscle, rhabdomyosarcomas or rhabdomyoma. Anything, for example, right? So I just gave an example of microscopic gland-like formation. We call it adenoid cystic carcinoma. That's how we name every epithelial tumor, right? So here, if a tumor has more than one germ layer, I call it based on the origin. If the origin is multipotent or pluripotent or a totipotent germ cell, I use the term teratoma. If the origin is epithelium, but in microscopy I'm seeing more than one germ layer, which is pleomorphic, multiple morphology. Since it's from epithelium, I call it an adenoma, right? That's why pleomorphic adenoma or mixed tumor of salivary glands. Again, two major things which I want you to remember throughout. Cancers or tumors will be monoclonal, which means every tumor cell will always be similar to the parent cell of origin. So if I know normal, like medullary carcinoma thyroid comes from parafollicular C-cells, so I can use them as marker. Not just for medullary cancer. I have a tumor of granulosa cells of ovary. Estrogen will be a marker. Inhibin will be a marker because they secrete inhibin. Right? I have a tumor coming from pituitary which produces prolactin. So prolactin will be a marker. So if I know normal, I can extrapolate abnormal, right? Other thing is every cancer will be hard on palpation because cancer means it has to invade. If something has to invade, there will be wound. Wound will definitely heal. It causes fibrous growth or desmoplasia, right? So in Robbins, this is what will be given in your first two things, right? So I'm going to give you a homework here. I want you to learn. I want you to learn what is these two terms. Just open Robbins, right? Just 2 minutes. Okay. I'll tell you exactly which page it is seen also. I think it is seen in the page below the table. I don't know. The online edition is seen in page 278, right? I have the book open, so only I'm saying that to you. Fine. I want you to learn these two terms, and I want you to tell what do they mean, right? A term called as an hamartoma. So what do you guys mean by hamartoma? And a term called as an choristoma. Okay. I want you to see, read it, and ping me on Instagram. I'll reshare it so that see. I want you guys at least till the end of neoplasia be with me. I have a very strong base on neoplasia because Robbins is more than enough for you to learn about neoplasia even till your DM. I'm not saying even MBBS, MBBS, MD, DM. Everything required for an understanding of cancer comes from Robbins only. Please don't let go of Robbins alone. These two terms, learn and ping me. Let's see how many of you do that. Fine. See you. See you in the next class. Till then, bye bye.